Today on Inside the Outcomes, my guest is Dr. Levi Hargrove, Scientific Chair of the Regenstein Foundation Center for Bionic Medicine at Shirley Ryan Ability Lab. His work focuses on developing technologies that allow prosthetic limbs to function more like natural ones by integrating robotics, neural control, and direct skeletal attachment, known as osseointegration, to help restore movement and independence. Welcome to the podcast, Dr. Hargrove.
Thank you. It's nice to be here.
So let's just start with maybe a definition of osseointegration. What is that?
So osseointegration is a scientific term for a direct skeletal attachment. And so normally when people wear a prosthesis, it's kind of suspended off of their residual limb, we call it, which is the point of where their limb had been amputated. And so it's kind of suspended using a socket, which is kind of like a well-formed fit shoe for the residual limb. And so it kind of hangs off of the soft tissue, and it is suspended to the person as best as the prosthetists, who are very skilled, can make it. In spite of that, it still sometimes doesn't fit quite well, or it can feel heavy or uncomfortable. So an alternative way is to actually put a titanium implant into the bone itself. So the prosthesis is suspended to your skeleton, like your arm would have been before it had been amputated in the case of an acquired amputation. And so this is a newer technique. It's been around, started in dentistry, interestingly enough, and it was used to hold implanted teeth back into the jaw, and that was developed in Sweden many years ago in the 60s or 70s for dentistry, and then it was brought into the field of artificial limb replacement a bit later by Dr. Rikard Brennemark from Chalmers University in Sweden.
What are some of the challenges that might be associated with osseointegration, and who's like the ideal candidate for something like this?
So osseointegration, again, started in dentistry. Hundreds of thousands, if not millions of people now have implanted teeth. There were always challenges bringing new technology. The primary challenge associated with osseointegration for limbs has been related to potential infection where the implant comes through your skin. And so your skin tissue is a little bit different than your gums, for example. So this hasn't been quite as much of an issue for the dental implants, but it is something that where you have this implant come through the skin, there's always been concern of an infection on the skin. And then if that infection gets a little bit deeper into the bone, it can be difficult to treat. So that has always been the concern and challenge. There are additional more pragmatic or logistical challenges associated with costs, associated with availability, and associated with just developing the evidence to show that this is it's good for patients, the outcomes are better, but also for economic impact as well from a reimbursement standpoint. So making sure that all of that the evidence is there and submitted has been a challenge. But the primary one has certainly been concern of infection. With respect to ideal candidates, because it's newer, we have this balance of risk benefit. And so individuals with higher level amputations for the upper limb, like at the humerus level, which is just above your elbow, they maybe have more to gain from a better attachment than someone who has their amputation below their elbow or at the transradial level. So they're a better candidate because there is still some risk associated with the procedure, so they'll potentially gain more function. Similarly for legs, individuals who have an amputation above the knee, particularly those that are very short femurs remaining, are good candidates for this because it can be very challenging for a prosthetist to suspend an artificial limb with someone who has a very short residual limb or very short femur. And so by using osseointegration, they're a very good candidate for this. And similarly, someone has a very short humerus on the arm, they're a very good candidate as well. It just is so much easier for the fit and more comfortable for the patient, and they get more immediate benefit. Other levels of amputation certainly might benefit, and they are under active areas of study.
So, how does osseointegration offer better functionality for the person?
Yeah, so you can think of the prosthesis as being kind of an extension of your body when it works well. And the better and more intimate that it's fit to you, the better you're going to be able to control it. It's like holding a tennis racket, for example. If you have a um, nice grip of a stiff tennis racket and you want to swing it, you kind of know where the end of it is. You can hit a ball. Imagine trying to hold a rubber tennis racket, or maybe a spring in the middle of the handle and try to hit a tennis ball. It can be very difficult to control the end of that racket. Similarly, for prosthetic limbs, if you have a soft tissue that the prosthetist has to grip onto with the socket, it can move around a little bit, and you can lose some of the fidelity of the control. There are probably many more benefits as well, but because it's newer, they're still being studied. We know that you can feel vibrations much better with an osseointegrated prosthesis, and that allows people to kind of get more confidence when their foot hits the ground, as an example. So there are many other interesting areas that I'm sure in the coming years will be studied to show changes and probably benefit.
And then we were talking the other day about this, and it's not just the osseo-integrated prosthesis that a person would get. It would be combined with some other technologies. Can you talk a little bit about that?
Yeah, so osseointegration on itself is an important improvement in technology and can be used by itself. There have been a number of innovative surgical techniques that have been developed, some developed here at the Shirley Ryan Ability Lab in partnership with our partners at Northwestern University. One of those is called targeted muscle reinnervation. Targeted muscle reinnervation is a way that you treat the nerves. It's a way that we access neural information by putting sensors over top of muscle. So we plug amputated nerve into muscle that's nearby after the amputation. The nerves grow into that muscle. And for example, you can plug a hand nerve into your bicep muscle. It will grow into the bicep. And when you think about moving your hand, your bicep will contract. That's called targeted muscle reinnervation. And so by combining targeted muscle reinnervation with osseointegration, we have this interesting opportunity where the implant goes through the skin. So we can put wires in through the implant and place the wires on the muscle rather than putting sensors on the skin surface. So by putting the wires inside of the muscle, we get a really clear signal. It's like listening to a conversation with someone in the same room versus trying to have a conversation with someone in a different room through a wall, which would muffle the sound. So you get this much more fidelity in the signal. So osseointegration is a really interesting approach to combine with implantable sensing and targeted muscle reinnervation, because we can access these really tiny neural signals and then use AI algorithms to decode the signals to tell the prosthesis how to move better. The same idea also applies for legs, and we're working in that direction, although we haven't done that quite yet here.
You have a grant from the National Institutes of Health looking at osseointegration and muscle reinnervation and pattern recognition in people with upper limb amputations. Can you talk a little bit about that research project?
Yeah, we're really excited. This is a project that we have been working on for several years, and we have now started recruiting patients into the study. So this is for individuals who have had their amputation at the transhumeral level, which is above the elbow. And what we're going to do is we're going to use an implant called OPRA. It's osseointegrated prosthesis for the rehabilitation of amputees, is what it stands for. And so they have this OPRA implant into the end of their humerus, so direct skeletal attachment, as I already mentioned. And we're going to put the wires inside through that implant and place those wires onto muscle and around nerves that have been partially amputated. And we're going to do the targeted muscle reinnervation procedure to get access to nice big signals. And so the idea is that we are going to compare people who have this advanced technique with implanted signals and osseointegration to what would be more of the clinical standard today, which would be osseointegration, but with surface signals and without having any nerve stimulation so that they can't feel the prosthesis. So we're going to combine all of these advanced techniques and then send people home with these commercial devices to see how they use their devices at home for a period of months, and then bring them back into the research laboratory to do some outcomes testing. And we're going to record data from when they're in the lab and also when they're at home, and get some survey information for how they like the new technology that they're testing.
And what can people do if they're interested in learning more about one of these studies?
So they can contact me. They can contact Laura Miller or Christy Turner at the Shirley Ryan Ability Lab. You can find their contact information on our webpage. They're heavily involved in co-leading the study with me.
I will be sure to link some contact information in the notes that go along with this episode. Thank you so much for being on the podcast today.
Appreciate it.
This podcast is supported by grants from the National Institute on Disability, Independent Living, and Rehabilitation Research. I'm your host, Sharon Parmet, signing off.